Well, hello everybody. My name is Garrett Schmidt, and I am the manager and CEO of BBC Exhibit Hall. And I would like to welcome you all to today's live webinar hosted by TCARE. And I apologize for any technical difficulties we had, but thank you for being patient with us. We are ready to go, so excited about our presentation today. A few items of note before we get started here. First of all, the presentation today is called Navigating Dementia Care: Comprehensive Support for Caregivers and Loved Ones Through the GUIDE Model. And I got a little bit of a preview the other day of what we're going to be talking about. I think you'll really enjoy the presentation today. A few items of note, again, some housekeeping items. Everyone has joined today in listen-only mode, so you don't need to worry about muting your mic or turning off your camera. That has been done for you. And we are going to have a time for some Q&A towards the end. So if you have a question at any point that you would like to ask our speakers, or just in general, you can drop it in using your module as an attendee. And we're going to get to as many as we can. If I know we got started a little bit later here, so if we don't get to yours for whatever reason, don't worry. Someone will reach out via email to make sure we answer your question afterwards. And then finally, the session today is being recorded. So what's going to happen is when we're done, you'll receive an email, and there will be maybe about an hour or so after we conclude, there'll be a link to the recording as well as to where you can download the slides. And that way you can watch it again and share it with friends and colleagues, and we hope that you do. So without further ado, wanted to very briefly introduce our speakers today. With us we have Ms. Jodi Fenner, and she is the Vice President of Growth and Execution at TCARE. And then we have Dr. Julius Bruch, and he is the founder and Chief Executive Officer of Isaac Health. So welcome to you both.
Thank you.
Great. Well, thanks everybody for coming today. And again, apologize for the technical difficulties. As Garrett said, I'm from TCARE, and the reason we're involved with this topic is we are an evidence-based caregiver support platform and concierge program, and we actually, through our different caregiving programs and partnerships, we actually partner with this amazing organization called Isaac Health on the GUIDE model, and we're excited to talk to you about that today. We're going to talk about, I'm going to introduce you to our Isaac Health partners, and then going to pass it over to Julius, Dr. Bruch, to talk about the dementia landscape. And then he's going to give you a good introduction to the GUIDE model, and we're going to tell you how you or the people you support can access those services. Before we get started, we want to know what your connection to dementia care is. So Garrett's going to pop up a brief survey.
Yeah, you're going to see this pop up on your screen here. And this is anonymous, so it's just kind of to get the audience involved here. So feel free to answer honestly. And we're going to show the results so you can see kind of where you stack among your colleagues. And the question is, what is your connection to dementia care? Is it, I know someone with dementia? That could even be yourself if you've had issues in the past. I am currently a caregiver of someone with dementia. I work with or support individuals with dementia professionally, or I work for an organization that supports people with dementia, or I'm not currently connected to anyone with dementia. And I'm guessing that last one's going to be kind of a low number because I think we all know somebody. So we'll give it another maybe 10 seconds for the results to come in. And by the way, this is a choose all that apply here. So you may be multiple of these things. I know that I certainly qualify myself. Okay, I think most of the answers have come in right now. So I'm going to shut it down in about another 5 long seconds, and then we'll take a look at the result here. And in 5, 4, 3, 2, and 1. Okay, Jodi and Dr. Bruch, are you able to see the results here?
I can only see my presentation, so no.
Oh, you can only see your presentation. Okay, well, I will read off the results for you, Jodi. 35% of us said that we know someone or directly connected with someone with dementia. 17% of you said I'm currently a caregiver. 46% said I work with or support people with dementia professionally, which makes sense on this webinar today. 61% said I work for an organization that supports people with dementia. And again, that makes sense for today's presentation. And then zero, which again doesn't surprise me, 0% of you said I am not currently connected to anyone with dementia. So clearly a common issue.
Well, thank you all. It always helps us to know who we're visiting with. And I'm not surprised at all either, Garrett. In our caregiver programs across the country, in our aging populations, and really anybody over the age of 50, it feels like I want to say the numbers are close to 80% of families impacted by dementia in some way. So it's a very important topic today, and we have the amazing Dr. Julius Bruch today to talk to us about dementia generally, but really about the guide model and that great opportunity for that comprehensive care. Dr. Bruch is not just the leader of Isaac Health, but he has an amazing background in neurodegenerative disease. He studied medicine at the University of Cambridge and has extensive healthcare practice consulting. So he understands value-based and digital health, as well as has great personal experience with his grandmother's Alzheimer's diagnosis. So he has experience from both the family side as well as the professional side, and we're super excited to have Julius with us today. And so, Julius, let's start with you sharing a high-level overview of the dementia landscape that's led to the need for this new model of care.
Well, thank you very much for having me, Jodi. It's great to connect here and be part of the webinar here and to tell people more about our great relationship and partnership with TCARE. So yeah, these are three great points why it's really worthwhile talking about dementia increasingly and why now is really the time to act. Because dementia is, as we may all be aware, a condition that's increasingly prevalent, and it actually affects 12% of all adults over the age of 65, and therefore is very relevant to many health plans. And it's also particularly common in certain groups, so especially in the Black American population.
Dr. Bruch, so sorry to interrupt you here. I think we're having some audio issues again hearing you. I think,
So sorry. Let
what if we
me.
could, yeah. Thanks for bearing with us, folks. We are working live here. Sometimes we have these issues. We had it worked out here before we began, and it switched on us. So,
Yes. Does this work any better?
it's very light. I'll tell you what. How about this? We'll call an audible. Can you give me a call on your phone again, and then I will literally hold your uh the speaker.
A few microphones, maybe.
Oh
Is this
wait, there we
difficult
go.
for you?
Got
There you go.
Yeah, that's much better.
Okay,
Perfect.
good.
Sorry.
Okay,
You may want to start over what
let
you were saying. So, thank you.
of course. Apologies about that. Well, thank you very much for having me, and it's great to be here to talk more about our partnership with TCARE. So maybe a few points just why it's worth, in particular, to discuss dementia now and why now is really the time to act. So dementia is obviously, as we may all be aware, a particularly common condition. It actually ultimately, at some point in our lives, will affect 1 in 3 of us. So most of us will either experience it in our own lives or be the caregiver for someone with dementia. And it affects 12% of the over age 65 population. So it is a big topic for health plans. And it affects certain groups, such as Black American and Hispanic groups in particular. There is also a very high caregiver burden as part of this. So 11 million Americans provide unpaid care for a family member or friend with dementia, and that obviously has a very significant cost. Uh, Most of which is not always easy to quantify and put into dollars, but there is a very high societal burden. Um, and one thing that we are particularly passionate about addressing is just that there's a really a big shortage of specialist care. So actually, over 20 states in the United States have been declared as a dementia neurology desert, so 40% of the entire US. And that really means that they have less than 10 neurologists available for every 10,000 people with dementia. And that means that the waiting times are really on the long side. So um, you can see the national average is 36 months. It's in many of the cities on the coasts, it's probably in the order of a year, but in much of the rest of the country, we are seeing 2 years, 3 years, and longer in terms of waiting times. And this is really the driver why very often it feels like a very broken care journey, why it gets detected long or detected late. Care seems often hard to find, the waiting times are long. And you can see here that it's really set to only become worse for the next few years, especially in the rural US, with waiting times of exceeding 4 or 5 years. Um, so yeah, this is sort of the journey that you may be seeing currently. Obviously, hopefully not in those organizations that have made it a priority, but um, so sort of just to walk you through a typical care journey, it's we see, for like, this is an example patient, Joan, who probably maybe at some point went to her primary care doctor and said, hey, I'm worried about my memory. And the doctor very often then says, oh, don't worry, it's part of aging. Uh, Let me know if it gets worse. And then very typical what we see is that then maybe several years later, maybe 4 or 5 years later, like it got worse. The like a family caregiver, like the son or daughter or spouse, brings her back in, and then the primary care doctor says, okay, it's now it's pretty severe. We need to make a referral to a memory clinic. That time usually then takes roughly a year or longer to see that specialist. Through that time, the caregiver increasingly burns out, and that's obviously then leads to sort of the symptoms getting worse. It leads to an increased chance of the use of emergency services, and obviously hospitals and emergency departments are pretty much the worst places for somebody with dementia to be. And very often they end up in a nursing home then much earlier than is necessary. And that's really the journey that we're trying to fundamentally disrupt here with this partnership, by addressing both the caregiver and the medical aspect of this.
Yeah, I would add to that, Julius, the critical um, that increased caregiver burnout. What we're finding in our early referrals is, quite frankly, because of the delays, by the time the caregiver is actually referred to us for that support, they're already in that burnout mode, and we're missing that opportunity to intervene early. But the other impact of that long waiting list and is something we were visiting about with the Alzheimer's Association. So many of the new medications and treatments that are available today are for early onset. And so these delays aren't just fragmented for the family, but they can actually impact quality of care. So excited to see some new models of care that are going to address that. And basically, so now let's move on, Julius, and tell us a little bit about the guide model, how it works, and how it really is changing the face of dementia care.
Yes, so the guide model is a new payment model from CMS, so from Medicare. It was launched in July of last year, so it's still pretty new and fresh. Uh, and what's really fundamentally new about it and innovative is that it covers not just the medical services for it, so access to specialty care and sort of a comprehensive assessment and medication management, but also sort of the social wraparound services. So members enrolled in this payment model have access to a broad set of services that span caregiver support, respite, care navigation, and then obviously the medical services. And so what we are offering here as Isaac Health, we are primarily a virtual memory clinic. So we provide all the specialist medical services. We have our behavioral neurologists and neurologists that really provide much faster access without the waiting times, generally within a matter of a few days or a week, so that patients can really get that diagnosis much sooner. And then uh, obviously, we work with TCARE for really providing many of these wraparound services. So that's really what's mapped out here. Maybe I'll start by walking through it, but Jodi, please feel free to add in. So the typical care journey starts with a referral, or sometimes we also reach out proactively. Then Isaac Health will do that comprehensive assessment. So we do this generally through telehealth, but wherever telehealth is a barrier to accessing care, we also work with in-home care aides that come into the patient's home and facilitate their visit. So they come with a device that has the internet in case there's a technology barrier. And then we will complete a medical and psychosocial assessment. We'll do the caregiver assessment, and then really have that comprehensive view that either leads to a diagnosis of dementia, or so if there is already a diagnosis, then just a baseline assessment. And then we also do an in-home assessment, which is very important to see how well the patient is set up, if there's any fall risks or safety risks in the home, and if there are any additional supports needed. And then we will take care of the medical care plan, so to make sure if there's, for example, any medication adjustments required to follow geriatric best practices, if a therapy such as cognitive rehabilitation therapy is indicated that may help this patient, if something like compensatory strategy training is helpful. So we'll make that care plan, and then at that point hand the patient over to TCARE, who will provide more of the long-term support services. And Jodi, I don't know if you want to add more to that.
Yeah, at the from the caregiver support perspective, they not only just have access to that 24/7 support line, but caregivers are matched with a TCARE specialist who has specialty training in dementia and supporting families with dementia. And we do that wraparound support using our evidence-based model, not just the caregiver's social emotional needs, connecting them to peer supports, different educational resources, but sometimes what we see as caregivers have given up their jobs, or there is a financial strain as well. So we also connect families to financial and other SDOH needs as well. And then we continue that one-on-one caregiver coaching and support throughout the program.
Great.
Yeah. And then, yeah.
Yes, so this is an overview over the comprehensive set of services that are covered by the GUIDE model, so that are covered essentially by Medicare. It includes on the left mainly the medical services, so that's the comprehensive assessment, care planning, and 24/7 access to a hotline with dementia specialists. That is in particular important to avoid any hospital and emergency department admissions, because often things like agitation or wandering happen at night, and that's when the caregiver will be most likely to get the help of emergency services. And we can obviously walk them through with evidence-based strategies to avoid that. And then on the right, you see many of those wraparound services. So the caregiver support is obviously that's TCARE's expertise. Respite care is in particular, I think, is a really unique offering in the GUIDE model, because usually Medicare doesn't pay for this, but through the GUIDE model, Medicare will pay for this. And that obviously makes it an attractive proposition, not just for the caregiver, but also potentially for any Medicaid LTSS plans who otherwise would be paying for this. And then there's obviously the care navigation to really make sure that the member and caregiver have access to all the right resources that are available to them.
And you all are virtual. You do virtual care primarily. And I think this is a map of your current coverage. Can you talk about a little bit about where you are operational and that flexibility to expand into new markets as needed?
Yes, so we're currently live in 22 markets, and our goal is to be in all 50 states by the end of the year. So we are currently actively pursuing this expansion. And however, we obviously always happy to be driven by partnerships. So if you reach out and you say you have a significant population in one of these states that are not dark green but light green here, then it's generally sort of a matter of 1 to 2 months to get fully set up in that state. So it's not a massive undertaking.
Okay. And you touched on this a little bit, but technology can be a barrier for some families, and it sounds like for families who don't necessarily have that technology access, you had an in-home option. How does that work?
Yes, so we do find that, not an insignificant proportion of the population generally has challenges accessing a telehealth appointment. And that may be because they don't have internet, or they do have internet but might not have the technological know-how and need help. And that's when we work with partner organizations like essentially home care agencies across the entire region where we operate, and they will send a home care aide to the patient's home. And so all they need to do is open the door, take a seat, and then they will facilitate that telehealth visit. And that's sort of how we find that generally pretty much everyone is able to access a telehealth appointment.
Perfect. That was really my point, was that even though there is that virtual component, that it is not, should not be a barrier for families. Let's pivot a little bit and talk about, is there anything else you want to share? I know Isaac Health is kind of one of those early innovators with the guide model. Anything you want to share about early lessons learned, how that's going?
Yeah, I think overall it's a fantastic program. The patients and especially their caregivers really appreciate that additional support, because it's generally heartbreaking to just speak to these people and hear just sort of how left alone many people feel, or how lost. And I think this program is really a great opportunity to provide that support and guidance throughout the journey. And as well, obviously, provide access to specialist care that otherwise is very hard to access. And through sort of this virtual delivery, we're able to, essentially really cut down the waiting time, as well as the maybe distance to travel to an academic medical center, which would otherwise provide these services. So yeah, I mean, the reception has been really positive.
That was the other thing I was going to ask about, is that transportation is a huge barrier to care for individuals and families supporting people with dementia. Getting out of the house isn't always convenient. And so are you getting feedback that virtual option is helpful and meaningful to families in that way?
Yes, definitely. Yeah. Especially, families where maybe someone is working or is working from home. It's a big disruption, or it generally, so if the family caregiver usually needs to take like half a day off work to get their loved one to an appointment. And this is really a way to cut that time down to maybe an hour, which is much easier to take off. So I think it's really a huge game changer in terms of access to specialty care in this space.
Yeah, the other thing that I love about Isaac, one of the things you're doing, and you mentioned this early on in one of the slides, that the number of dementia care specialists, just the sheer volume, is not there nationally. And I know you have gone into markets and states and areas and collaborated to increase the number of physicians who are considered to have that dementia specialty training. What are some ways that you go about that? Because I think that's really critical for a lot of people, is just that access.
Yeah, exactly. Yeah, so I think just the fact that it is virtual allows us
Mhm.
to have these specialists in place, because it is ultimately a very attractive work environment for them to be able to work from home, and that also from wherever they are based, so they don't need to commute to a hospital either. And I think that allows us to really recruit those specialists and provide access to them. I think that's sort of what makes the main difference here.
Yeah. I mean, just the sheer volume of your network and how you're able to get people in a matter of weeks and months and not years. It's just so
Exactly.
critical.
Yeah.
I would want to pivot now to talk about how individuals and organizations can access guide model services. Obviously, there are hundreds of organizations across the country that are delivering or have been approved to deliver guide model services. Here at TCARE, we are partnering with Isaac. Quite frankly, we love that ability to touch more of our caregivers since we support across all 50 states. We're excited for Julius, Dr. Bruch, and team to be in all 50 states. Um, but so let's talk a little bit about the criteria, right? Because not everybody can do it. Not everybody is eligible for that Medicare funding. Julie, do you want to kind of talk through the eligibility criteria?
Yes. Yeah. So there are some criteria. So the most important one is really that the member is enrolled in Medicare Parts A and B. So anyone enrolled in the Medicare Advantage plan, unfortunately, is not eligible for the full guide program. We can still sometimes see if there's certain services we can still provide, um, but generally they would be more on the sort of medical side. Um, and then there needs to be a diagnosis of dementia, but that's something we can do. So we can make that diagnosis as part of our service. And then a few sort of smaller eligibility criteria are that they are not residing in a long-term nursing home, because then generally they already have all of those support services, that they're not in a hospice, and that they're not enrolled in a PACE program.
Okay. So individuals who are in Medicare Advantage wouldn't necessarily qualify, but that Medicare Part A and B, they can have Medicaid though, right? They can be in Medicaid LTSS, they just can't be in Medicare
Absolutely.
Advantage.
Yes. Exactly.
Perfect.
Yes. And we
And I,
find actually that that's sort of yeah, that's a very good population to target, those enrolled in the LTSS plan, because they very often then do have Medicare Parts A and B, and but they have the need.
and so you do work with managed care organizations and hospital systems, things like that, to make availability to that LTSS population in Medicaid.
Exactly. Yes.
Perfect. We are showing a link today. I know we have individuals who could be eligible or who have family members who are eligible on this call. We also have organizations. And so organizations that support individuals or dementia with caregivers, if you're out there and you would like a flyer, something, a handout that you can give patients, or individuals that you support, we're happy to um, customize those for you. But for individuals or caregivers, you can actually access the guide model program directly through our site, together.mycare.ai/Isaac, or we have a QR code, and we will send this out to the group after this call. But anything else you want to share about the model? I mean, to me, it's a really great, innovative model. It's nice to think that families on Medicare can access respite services, whereas traditionally you have to go on Medicaid, and um, that that isn't a good fit for all families from an income base and other. But to have that broad circle of support around families. Anything you would like to add or share, Julius, before we open it up for questions?
I think nothing in particular. I think let's be guided by the questions,
Yeah.
and obviously have to address those.
Perfect. Okay.
Right. Well, we do have some audience questions today, and again, I appreciate you all bearing with us. We know that we've got some audio issues going on, so thank you for your patience. So we're going to get to as many of these questions as we can. I think we've got a good amount of time. First question is this, and Dr. Bruch, I'll have you just, if you don't mind, speaking as loudly and clearly as you can because the audio is very
Yeah.
faint. I know that's not your
Okay.
fault, but it's just
Um,
something that's
I'll do
going
my
on
best.
with the audio. Yeah. Okay. First question is this: is how does the model address changes in behavior and cognition as dementia progresses?
The model is there to maintain the cognitive performance and maintain the independence of the member for as long as possible. Um, in terms of so we on the medical side, we do offer some solutions. So there's obviously certain medications that can be that can really support cognitive function, and we will obviously have our doctors review whether one of those medications might be a good fit. Um, and that's not necessarily the new more expensive ones. Like there's also um, yeah, there's a broad set of options. Um, and then there's also the things like cognitive rehabilitation therapy, which is an evidence-based therapy that's actually following the guidelines of the American Academy of Neurology. It's mainly for individuals in the earlier phase of the journey, so more on the mild cognitive impairment and early stage dementia, that I'm highly motivated to work on it. But then that's an evidence-based therapy that can really improve cognitive function. Well, otherwise, the goal of the program is really just to make sure that the individuals and their family are well supported and to stay as independent as possible for as long as possible.
Yeah. And I would say having access to that dementia specialist from the caregiver perspective, as well as connecting caregivers to training and education on what to expect, what are ways to engage with a person in dementia who may be escalating from a behavioral perspective. You know, because what we know is behaviors are often a communication of a frustration internally. And so we find that if we can equip caregivers to know more what to expect as the disease progresses, that, you know, supporting that family holistically, we see better outcomes for the individual with dementia as well.
Wonderful. All right. Next question is: does the guide model support non-pharmacological interventions for agitation or wandering?
Um, yes, so there are definitely some evidence-based strategies that uh, that we can work with the member or their family member to work through in those instances to if there is a desire to avoid medication. I know, Jodi, if you have, so if on the TCARE side you have the particular strategies there that you would walk people through.
Yeah, I mean, there are quite a few, again, different skills development, different conversational techniques. It depends on the family dynamic and the caregiver role. But definitely there's a lot of great evidence-based, evidence-focused training and education and support that we can provide to the caregiver. Uh, I hear the question because so much of the focus today seems to be on medications. And my understanding, and I'm not the doctor, so I'll have to defer to Dr. Bruch, but my understanding just from the education in the field is that most of the medications are only helpful for that in those early phases of the disease. And then quite frankly, a lot of the cognitive support and those programs are also more effective at earlier phases. But what I love about Guide is families actually can ask the questions from the physicians because you have these dementia experts that you're dealing with, whereas your primary care physician and a non-dementia expert may not help you to understand like the differences between some of the new medications, the differences between some of the therapeutic non-pharmacological solutions, because it can be it's an emerging field with a lot of new innovative supports. And so being able to support the family in identifying what those are and having them equipped to make those decisions for their care that is that best fits the individual and family needs, I think is really critical.
Great. Next question. How does the model support co-occurring behavioral health conditions like depression or anxiety?
Yes, so obviously it's very common that dementia occurs alongside some of these conditions, and so there again, so if I think we will answer the question in two parts, right? On the medical side, there is obviously will do medically manage those conditions. So that may again be medication, but very often these patients also benefit from something like therapy. And we actually do have therapists, like psychotherapists, available that do cognitive behavioral therapy for some of those comorbidities, and that can be very effective. Um, and then there is also the obviously the support throughout that is important. And so the care navigators on the TCARE side would, I'm sure, also be able to just sort of work through some of those evidence-based strategies and manage it. But Jodi, if you don't know if you want to add to that.
Yeah. One of the things we find with this population is often the caregiver and care receiver are on the same MA program, or the same Medicare program. And so oftentimes we can, the good thing about that is we are able to also connect the caregiver to physical and behavioral supports as well. Whereas in some of our other programs outside of the GUIDE model, the caregiver may be uninsured, they may have a completely different insurance package, but we do work with the caregiver to help them not just address their own personal situation, because caregivers also experience enhanced rates of depression and psychological challenges when supporting somebody with a long-term illness like dementia, but also helping them understand what their loved one is going through. And sometimes their ability to understand and provide support for the individual with dementia can also complement the work that the medical team is doing.
Great. Next question here is, I believe you said this service is covered by Medicare. Is that correct? And does a patient have to be referred by a PCP or other provider, or can they self-refer to Isaac Health? Thank you.
So they can definitely self-refer. Yes, so the program is covered by Medicare, and a PCP referral is not required. We will obviously generally try and loop the PCP in as much as sort of is wished by the PCP. So we will inform the primary care doctor that the member has enrolled, and we will then sort of share any records and sort of notes as well that may support the primary care doctor, because the last thing that we want to do is fragment care. So we want to make sure that everything is coordinated.
Agreed.
Wonderful. Next question here is, I work for an ADRC providing grant funding for caregiver respite. Am I understanding that TCARE will facilitate referrals from guide workers to me at the county ADRC?
It depends on the area. We actually do the guide care management through our centralized TCARE team, but from that respite, depending on the state, we might work through the local AAAs, as well as we have different respite providers that we partner with in different markets. So it definitely depends. Would love to reach out. The one thing I would say also is the guide referrals can be a tool for the local area agencies on aging, because remember, this respite is paid for by Medicare. So you don't necessarily have to take that out of your grant funding that you're providing respite to. So if you have somebody who would be eligible, who's dementia, might be eligible for the guide model, you could provide support alongside while they're getting that support in the guide program, and that family could then ultimately have more access to respite, which can be really critical at different phases of the disease. And what I would say is if you're in a AAA, let's reach out and let's talk. How can we collaborate? Because I think it is a mutually beneficial program for both of us.
Yeah,
Very
and
exciting.
maybe I'll just add from the Isaac Health side. So if you would like to be a guide respite provider as part of this arrangement, then um, yeah, obviously please reach out, and then we have sort of a fairly straightforward process for getting the CMS and Medicare approval, because we do need to go through that.
Yep, absolutely.
Wonderful. All right, moving right along. We got a lot of questions today. Again, if we don't get to yours, though, don't worry. Someone will reach out via email afterwards. But go ahead and drop your question in now using your attendee module. All right, next question is this. The guide model is currently only paid for for patients with traditional Medicare. Do you have any success with Medicare Advantage plans?
We are actually
Uh,
talking to some Medicare Advantage plans, even though Medicare wouldn't cover the guide model in its form, because you have to just be Medicare Advantage programs can't bill for the guide model. But the model itself leads to cost of care and positive outcomes for members. So we are seeing Medicare Advantage plans want to consider approaching implementing guide models as like supplemental benefits, those additional caregiver supports and potentially respite or bits and pieces of that, right? So you can't bill Medicare under the traditional guide model the way it's drafted today. But if there are Medicare Advantage plans or hospital groups, ACOs, the folks who have an incentive to do value-based care, then I think we would definitely be open to discussing what that might look like.
That's actually a great segue into the next question here, and you may or may not have this ready at the moment, but it says for ACOs, guide payments I'm sorry, for ACOs, guide payments will increase total spend per attributed beneficiary per year. So is there any ROI of this guide program for ACOs that you could share?
Yeah, I mean, it goes back to the whole notion of managed care, right? You're increasing getting somebody into that dementia care earlier, but sometimes those virtual visits can be less expensive because you're not having to arrange transportation. So there is that savings to the virtual uh, model of care, but it's also getting individuals and families that wraparound support is going to reduce your visits. It's going to ensure that those families have their comprehensive needs met. Because remember, the care management part of that, we're not just connecting them to health plan benefits, we're connecting them to community resources and benefits. Some of that might be the AAA question we had above, that because there is limited respite under the guide model, and so maybe we also can connect them to other community support services. So you're right, there is a cost to it because it would be a claim, but it's getting people services earlier, and ideally that is going to have a positive impact on their general overall cost of care and quality of life. Instead of spending time in an emergency room because of a behavioral episode, as
Mhm.
Julius mentioned earlier, there are things that we can do to equip families um, to reduce that more intense level of care. And Julius, I should let you speak to that. You're the doc, but
No, no, I think everything you've said is absolutely spot on. I mean, it's sort of to quantify it, we see an ROI of roughly 2 to 1 on for ACOs specifically. It's higher
Two
for
to one.
Medicare
That's great.
Advantage plans, but because ACOs don't get the revenue benefit of the program, it would mostly it would be in the order of 2 to 1.
Wonderful. Next question is this. How is the respite accessed through the guide model?
The respite access.
Yeah, the question is how is
Yeah.
respite accessed
Access. Yeah.
through the guide model? I don't know if that makes sense to you.
So if you enroll in the guide model and are approved, it's Medicare that ultimately does the approval. Then the respite is just access through the Care Navigator, and
Through the
we
Care
also have an
Navigator.
online form that's available. Then if anyone wants to directly request it, so there's also that option. But otherwise, it would be through the Care Navigator.
Okay. Uh, Next question is this. If a patient comes to you with a diagnosis of dementia already, is there an area on the FAST scale that they need to be?
Yes, they need to be at least four or above on the FAST scale.
4 or above?
Yeah. So they need to have not just mild cognitive impairment, but actual dementia.
Got it. Next question is, and this person says, I'm sorry, but with the sound issues, having a little bit trouble. But the Isaac model can provide respite. How long does someone need to be involved in order to receive respite?
There is no shorter limit that's immediately available upon enrollment.
Wonderful. Okay.
And apologies about the audio. I'll try and get as
No,
quick
not your.
as
Let's
possible.
see. And okay, next question is this. How are family caregivers involved in care planning and decision making?
That's a great question. I'll answer it from the medical side, but then we'll hand over to Jodi. So on the medical care planning, when it's more about sort of which medications are indicated, which therapies, which treatment options, that is, we usually do a specific care planning session, and that would ideally be attended both by the patient or the member with dementia, as well as their family caregiver. It's very much, I think we try and really make sure that it's a joint decision-making process, because very much it's a condition that affects the whole family. Um, Jodi, I don't know if you want to add more from
Yeah,
the.
and this is a really critical question because what Julius just said, it happens in day-to-day life. The wife or the immediate family member who's supporting the individual is typically aware. One of the, and involved in those appointments. One of the things we work with caregivers to think about is expanding that circle of support and awareness. Want to be very respectful to the wishes of the person with a diagnosis because they are in control of their own private information, what they want shared. But I will tell you, in our work with families in dementia, just in this past year, one of the things that we noted was, and this was in a comprehensive dementia program. So every person in this program had a diagnosis of dementia and was in a comprehensive program. We had 30% of their caregivers who we were supporting who didn't realize they had dementia. Like they weren't in the know, so to speak. They knew they were supporting their family member who was aging, and they were getting support to do that. And what that results in, though, is problems because, as has been discussed, sometimes there are symptoms of dementia in later phases. There are behavioral challenges, things that you may not realize that can really negatively impact that caregiver relationship if the caregivers aren't, and the extended family caregivers aren't in the know. So we really try to talk to the primary caregiver who we work with, and also the patient with dementia, of considering expanding that. Again, want to be respectful to privacy, but with dementia, it's critical that the people around you know what to expect so they can provide you the best support. And your immediate caregiver, oftentimes that's a wife or an adult child or something, they're going to need support along this path. This is a long path. And so expanding that circle of support, because it is critical to have that family engagement in those clinical decisions.
Yeah. All right. Next question here is, and we got a time for a couple more. What supports are built into the model to reduce caregiver burden?
So we actually, from the caregiver burden perspective, I think the respite alone is a game changer. But
Hmm.
we do we have an evidence-based screening and assessment discovery process that we use to identify um, across different areas of caregiver burdens, what is driving that individual caregiver stress, because it's going to be something different for every family, and then being able to customize that care plan to support them, but using that access to 24-hour support, that call line, dad wakes up in the middle of the night and I don't know what to do, I can call and talk to somebody. Or and then having that caregiver specialist who can connect them to things like respite, but also other support programs as needed. Sometimes long-term care planning, financial planning. We have different community organizations that we can connect people to, because again, with dementia, the length of that, sometimes that impacts estate planning and other things that people need to be thinking about. We don't provide those services directly, but we can support families in understanding the different types of things that they need to address. And sometimes just that support, knowing what's out there, knowing what's coming, knowing what you need to be engaged with as a caregiver, can actually reduce that stress level. But in all honesty, that respite is probably a big game changer too.
A couple clarification about the respite. I'm wondering if you could clear up, and this may have been due to some of the audio issues. We had a question that says, I would really be interested in more information on the respite. How much is available, and is that something that Medicare is paying for, and thus is there a copay? And that, are you able to speak to that?
Yes. So actually, that's a great point. We should have mentioned that. So the whole program is exempt from copays. It's completely free to the member.
Exempt from copay. That's wonderful.
Yes, so there's no copays on the entire program, and that includes respite care. In terms of what is available, it is unfortunately capped at roughly, it works out as 21 sessions of 4 hours in-home care per year per member. Yeah, 21 sessions of 4 hours.
Great.
There is
Thank
also
you.
the option that's for in-home respite care. There is also the option to do like a daycare facility, but I would say by the in-home care is obviously much more popular.
Perfect. Yeah, thank you for that clarification. We got time for a couple quick last ones, and then we will have to wrap up. This one says, I may have missed this from Jodi's initial presentation. For their supports, is there a tablet or virtual learning or printed resource education binder provided in the home, or is it all phone-based?
We have a lot of virtual resources. We have an Odyssey platform. So in addition to the telephonic virtual support, we can provide access to a variety of information online. We also can mail information. Again, we spoke to not everybody has a computer, or sometimes they prefer printed documents. We work with a couple of different content partners who are experts in the field, and we can also provide written materials in the family home if needed. But yes, there's a broad array of online learnings and educational resources and materials, but we don't let technology be a barrier. We are a technology company in part, but we understand that the most important thing is meeting people where they are, whether that's paper, electronic, or in person.
Understood. Understood. Well, unfortunately, we are out of time, and I wanted to thank you, Dr. Bruch. Thank you, Jodi, for a fantastic presentation. Thank you to our audience for sticking with us through some technical issues. Obviously, there's a lot here, and of course, if you want to know more or get any clarification on anything you may have missed, feel free to reach out. On your screen, you are seeing TCARE has a virtual exhibit booth available at vbcexhibithall.com. So as we wrap up, wanted to encourage you to head over to vbcexhibithall.com, where you can check out their virtual booth and, of course, read up on them. There's a lot of other great resources there as well. This is where the archive, or this webinar rather, will be archived in the library there, along with some of the other materials that TCARE and others have produced, and all of it is free of charge. And so yeah, take a look around there. And then if you would like to reach out to the TCARE team, feel free to reach out to Jodi's information is here on the screen, and she'd be happy to connect you with the TCARE team and or Julius, Dr. Bruch. Thank you guys so much again for joining us today. Hope you will join us for the next one. And until then, hope you have a wonderful rest of your day. Bye-bye now.
Bye.
Fantastic. Thank you.
Thanks.